Next chapter we will take on cornea. And we have discussed one disorder in the cornea, which was keratoconus. Can you tell me where we have studied keratoconus? In anatomy, where we have discussed keratoconus? Link. So link was a mnemonic for prominent corneal nerves, right? Where L stands for L for leprosy, I for idiopathic, N for neurofibromatosis, and K for keratoconus. So as I told you, kerato means cornea and conus means cone-shaped cornea. So when the shape of the cornea is altered, it becomes conical in shape. That condition is called as keratoconus, and it is a pathological state. Can you appreciate normal cornea and this conical shaped cornea? Conical shaped cornea, right? So as I told you before also, when we were discussing accommodation, whenever the be it cornea or lens, curvature changes, power of that structure automatically increases. You remember that? So that rule is also applied in keratoconus also. Clear? So whenever the curvature of the cornea increases, it becomes more curved, right? The curvature, the shape of the cornea becomes more cone shape. So curvature increases. So automatically what will happen to the power of the cornea? It will increase. Normal power of the cornea is 44 diopters, right? 43 diopters, right? So in keratoconus, the power of the cornea will automatically increase. This much is clear? Give me a thumbs up. Okay, write down. Write down the definition of keratoconus. Keratoconus. Definition, write down. It is a non-inflammatory condition. And it is a progressive one. Non-inflammatory progressive disorder characterized by inferior corneal steepening. Inferior corneal steepening. And your cornea becomes conical in shape. It becomes conical in shape. So the cornea as a whole, there is not the steepening of the cornea. The steepening is more prominent in the inferior part of the cornea. Steepening means the curvature of the cornea is becoming more conical in shape. So that this is the definition, and it is a progressive condition. If you don't treat it on time, the conical cornea will become more and more conical in shape. Okay. Now coming to etiology. Etiology of keratoconus. First is VKC. VKC is vernal keratoconjunctivitis. Conjunctivitis. This is an allergic disorder more commonly seen in young males. We will discuss in detail in conjunctiva. Second etiology, write down. It is commonly seen secondary to trauma. Secondary to trauma. It is associated with Down syndrome. Down syndrome. Can you tell me where we have studied Down syndrome previously? Which condition of cornea was associated with two syndromes? One was Down syndrome and another one was Marfan syndrome. Can you recall which pathological condition of cornea was associated with Down syndrome? Macrocornea, correct. Macrocornea was associated with Down syndrome, and microcornea was associated with congenital rubella syndrome. Congenital rubella syndrome. Okay. Now, fourth etiology, write down. It is seen due to congenital weakness of cornea. Congenital weakness of cornea. Coming to clinical features, write down symptoms first. Symptoms. So patient will present to you with myopia. Patient will be having myopia, high degree of myopia. Patient will be having myopia with irregular astigmatism. Irregular astigmatism. Clear? What is irregular astigmatism? We will discuss in detail in optics. Okay. Patient will be having myopia with irregular astigmatism. This is an important question. The presenting complaint of the patient will be that the patient will complain to you with frequent changes of glasses. Write down. Patient will complain to you with frequent changes of glasses. So patient will be a young 16-year-old, around first year MBBS guy. He will come to you with the complaint of frequent changes of the glasses, and on refraction you will see that the patient is having high myopia with irregular astigmatism. Myopia means which power? Minus power or plus power? Minus power, right? We prescribe minus lenses in myopia. Which glasses we prescribe in presbyopia? Presbyopia. Which glasses? Convex or concave? Convex glasses, right. Convexes are the plus glasses. Good. Now coming to signs. What signs you see in keratoconus? So very, very important for your exam point of view, this keratoconus signs and clinical features. To remember the signs, you need to remember the mnemonic cones. Keratoconus, conus, you have to remember cones, right? Where C, cones, C stands for, write down. C stands for central scarring. Central scarring, which is called as acute hydrops. Acute hydrops. Now try to understand what is happening in the keratoconus. See, suppose this is my cornea. This is my normal cornea. What happens in keratoconus? This normal cornea, it assumes conical in shape. It becomes more conical in shape, right? So what will happen if it is becoming more conical in shape? the thickness of the cornea will automatically reduce. There will be thinning of the cornea, right? There will be thinning of the cornea. And one stage will come when there is extreme thinning. One stage will come that there is so much thinning of the cornea that automatically, which liquid is present behind the cornea? Aqueous humor, right? So one stage will come that your Descemet's membrane will get damaged because of extra thinning, and the aqueous humor will seep inside the inner layers of the cornea, and it will give you corneal opacity. That opaque cornea is called as acute eye drops. That opaque cornea or central scarring, which is seen because of aqueous entry, that condition is called as acute eye drops. And how it looks like, this is, can you see the whitish part in the center of the cornea? This whitish central opacity is called as acute eye drops. This is seen in keratoconus, in advanced stages of keratoconus, when there is extreme thinning in the inferior layers of the cornea. See, this is, it becomes more conical in shape, right? So whenever there is excessive thinning of the cornea, then what will happen? Which liquid is present behind the cornea? Aqueous humor. Aqueous humor will seep inside the inner layers of the cornea, and the normal transparency of the cornea is lost, right? Cornea will become opacified, and this will give you condition called as acute eye drops. Clear? Give me a thumbs up if it is clear. Okay. So this is how your acute eye drops looks like. Now coming back to another signs. C for central scarring. C for central scarring. Next, write down O. O for oil droplet reflex. Oil droplet reflex. Now, when suppose the pupil is dilated of such keratoconus patient, suppose we dilate the pupil with atropine or any other dilating drop, and we examine the fundus of the patient. If we see the pupil of the patient, how the pupil looks like, how the pupil looks like, see in the image. Can you appreciate a central opacity is there? Now, suppose this is the side view of the cornea, and this is a prominent shape of the cornea, prominent peaking of the cornea, conical shape. Now, if you see this cornea from the front side, you will see a central oil droplet reflex against the red glow of the choroid. So this oil droplet reflex is characteristic of keratoconus. Understood? Very important question. Oil droplet reflex is seen in keratoconus. This white dot is your cone like this. This is your cone which you are seeing from the front side. So this is a oil droplet reflex. Next sign, write down CON. O we have discussed oil droplet. N for corneal nerve prominence. Write down N for corneal nerve prominence, which we have already discussed in the mnemonic link. K for keratoconus, prominent corneal nerve are seen in keratoconus. E stands for excessive bulging of lower eyelid. Excessive bulging of lower eyelid, which is called as Munson sign. Which is called as Munson sign. Important, very, very important question. Now, suppose this is my cornea, right? This is my normal shape, and this is my conical cornea, right? Now, with this conical cornea, if I look in the downward gaze position, in my downward gaze position, there will be a bulging of my lower lid. There will be excessive bulging of my lower lid in downward gaze position. This sign is called as Munson sign. This sign is called as Munson sign, and this is how it looks like. In a conical cornea, if you ask the patient to look in the downward gaze position, there will be a V-shaped conformation or excessive bulging of lower eyelid, This sign is a typical finding of keratoconus known as Munson sign. Very, very important. Now coming to next, last S. S stands for striae, and it is called as Vogt striae. Vogt striae are seen in keratoconus. S for striae, and which striae? Vogt striae. Vogt striae are seen in keratoconus. Can you appreciate this picture? Can you see these stress lines are seen on the magnified view? If you see the magnified view of the cornea, you will see slight vertical lines on the cornea. These striae are called as Vogt striae. Typical finding seen in keratoconus. Vogt striae. So these were the signs, and the mnemonic was cones, right? So next, write down. These were the signs. Now this patient has come to you in OPD, right? Now you want to confirm that this patient is having keratoconus. What all investigations you will carry out? So this is a problem of cornea, right? So definitely when there is corneal nerve prominence, you have to check the corneal sensations also, right? So how you check the corneal sensations? With the help of which reflex you check? With the help of cotton wisp. Like this is cotton wisp. You bring the cotton wisp from the lateral side and you touch the wisp with cotton wisp with the tip of the cornea and you check the blink reflex of the patient, right? So write down investigations. Next heading is what all investigations you carry out in a patient whom you suspect keratoconus. So how you check blink reflex? I am repeating. You take the cotton wisp, tip of the cotton wisp, and you take it from the lateral side. Ask the patient to look in the straight gaze position. You touch the tip of the cotton wisp with the tip of the cornea. And when the patient blinks, you check the blink reflex of the patient. Okay? This is how you check the blink reflex in the OPDs. Now write down investigations. Investigation, write down. You test the corneal sensations. Corneal sensations are checked with the help of blink reflex. Can you tell me now the blink reflex, the afferent pathway or the efferent pathway is regulated by which cranial nerve? Afferent pathway. Afferent pathway of blink reflex is regulated by which cranial nerve? Trigeminal nerve. And the efferent pathway by facial nerve. Very important question. So this is the first test which we carry out. We check the corneal sensations, right? How you make the diagnosis? How you make the diagnosis? You make the diagnosis with the help of it investigation, which is called as, we have studied this one, corneal topography. Corneal topography. Topo means surface, right? So this keratoconus is also a disease of pathology of surface, right? So corneal topography is the gold standard investigation. Write down. Important question. If they ask you which is the gold standard investigation for keratoconus, then answer will be corneal topography. Answer will be corneal topography. Clear? Yes. Next investigation, you have to check the corneal thickness. You have to measure the corneal thickness Now you will tell me by which technique, what is the name of the technique by which we measure the corneal thickness? What is the name of that investigation by which we measure the corneal thickness? Keratometry, no, right? No. Keratometry is not. By keratometry, you measure the radius of curvature of anterior corneal surface, right? By help of pachymetry. Pachymetry is the right answer. By the help of pachymetry, we measure the corneal thickness. Obviously, we have to measure the corneal thickness because in keratoconus, because of continuous cone-shaped cornea, the thickness of the cornea is constantly decreasing. So you have to measure the thickness of the cornea. Okay. Topography is the gold standard investigation for keratoconus. Clear? Now you will tell me what is the aim of the treatment in keratoconus. Coming back to treatment right now. Before knowing the name of the treatment, you have to know that what is the basic principle, what should be the aim of the treatment you are focusing upon, right? So what is the pathology? The cornea is becoming more and more cone shaped, right? And there is excessive thinning of the cornea, and it is a progressive disorder. So by anyhow, if we provide strength to the cornea, this the conical shape of the cornea, this progressive process can come to a halt. We can reduce the progression of this disorder if we provide any strength from outside to the cornea, right? So if we provide strength to the corneal stroma, by anyhow, we can decrease the progression of this disorder, right? Now, there are certain methods by which we can decrease the progression of this disorder. Write down the treatment options. First, we can give rigid contact lenses to the patient. First treatment option, we can give or we can prescribe rigid contact lenses to the patient. But what we see in clinical setup, the patient is not very happy with the contact lenses because the curvature of the cornea is constantly changing. So patient is not very comfortable. Patient complains of watering and foreign body sensation. But still, it is a treatment option. Second option, second technique write down is called as INTAX. INTAX, INTACS. INTAX is, full form is intracorneal ring segment implantation. In implantation. So what we do in this, suppose this is our cornea. In the cornea, there are bean-shaped rings are present, kidney-shaped in the cornea, kidney-shaped rings are present. So this is our cornea. We'll make an incision in the cornea and we will take these rings, kidney-shaped rings, and we will insert these rings inside the inner layers of the cornea. These rings will provide strength to the corneal stroma, and automatically the progression of the corneal steepening will come to a halt and the progression can be decreased or progression can be slowed down. So this is also a very commonly used technique in keratoconus treatment, which is called as INTAX, and this is important for your exam. So what we do in INTAX, we implant kidney-shaped or bean-shaped rings inside the inner layers of the cornea, which provides strength to the cornea. Clear? Now write down the third treatment option. Third is keratoplasty. Kerato means cornea, plasty means transplant. So we can also transplant the cornea from the donor. Clear? Fourth treatment option, which is very, very important for your exam. Very, very important. C3R, it is called as C3R, CXR or CCC. It has three names, and the full form is corneal collagen cross-linking. Corneal collagen cross-linking with riboflavin. We use ultraviolet A rays. Ultraviolet A rays are used of 370 nanometer. So what is the basic principle behind the C3R? You need to understand. This much is done. Have you written this? Corneal collagen cross-linking with riboflavin, UVA 370 nanometers wavelength is used. Very, very important. You have to remember 370 nanometer also. You have to remember this riboflavin also. Okay. Now let us see the image. What we do in C3R. See, this is how the patient is made to lie down in OT. Put some topical anesthetic eye drops. Right? They scrape the cornea which is steepened, and we apply riboflavin eye drops over that part of the cornea. And after 30 minutes, we expose the cornea with UVA light for 30 minutes. Now, what will happen to the cornea? As I told you, which is the thickest layer of the cornea? Stroma, right? Stroma constitutes 90% of the collagen fibers. 90% of the corneal thickness is constituted by a stroma. And this stroma is made from keratin sulfate, right? So it contains collagen fibers. Collagen fibers are arranged parallelly. In stroma of the cornea, the collagen fibers are arranged parallelly, right? Now, by any technique, if I induce covalent bonds in between these collagen fibers, it will provide strength to those collagen fibers. It will provide strength to those collagen fibers. How I will induce covalent bonds between those parallelly arranged collagen fibers in the stroma? With the help of UVA light. With the help of UVA light, 370 nanometers, I will induce covalent bonds in the collagen fibers which are parallelly arranged in the stroma of the cornea. So in that way, I can reduce the progression of the keratoconus and the progression can come to halt. So if they ask you which is the standard treatment for keratoconus, answer will be C3R. Answer will be C3R. C3R, like gold standard investigation was corneal topography. Similarly, the treatment of choice will be C3R. Understood? The concept is clear for C3R and keratoconus. Give me a thumbs up if it is clear. Basic aim of the treatment is to strengthen the cornea so that we can reduce the progression of the corneal steepening. Give me a thumbs up. Okay. So after keratoconus, we will discuss next important topic, which is called as corneal ulcer. Write down. Next important topic is corneal ulcer. Ulcer, as you have also discussed this corneal ulcer. So here corneal ulcer is any discontinuity in the corneal epithelium. If there is any discontinuity in the corneal epithelium, suppose a foreign body has fallen in the cornea, and because of that foreign body, their epithelial defect is there in the cornea. Because of that epithelial and infiltration of the subepithelial tissue, which will lead to corneal ulcer. That will lead to corneal ulcer, right? So write down. In corneal ulcer, first we will discuss bacterial corneal ulcer. In bacterial corneal ulcer, we will discuss the most important questions which are commonly asked in your exam. Write down. If they ask you question number 1, most common cause of bacterial corneal ulcer worldwide, not in India, worldwide. Staph aureus. Most common cause of bacterial corneal ulcer worldwide, answer will be Staph aureus. India, most common cause of bacterial corneal ulcer, then answer will be Streptococcus pneumoniae. Streptococcus pneumoniae. It is also called as Ulcus serpens. Important question. All of them are important. Ulcus serpens. Next, if they ask you most common cause of bacterial corneal ulcer, users. So the patients who are using contact lenses for extended period of time, more than 8 hours, so they get bacterial infections. So you have to remember, most common cause of bacterial corneal ulcer in contact lens users, answer is Pseudomonas. Pseudomonas. It is in Pseudomonas corneal infections, you will see green color discharge. That the patient is getting green color discharge. Then blindly you can tick the answer as Pseudomonas. This Pseudomonas infection is very, very severe. Why? If in question they are saying that in 72 hours or in 3 days, because of bacterial corneal infection or bacterial keratitis, there is corneal perforation. It indirectly says Pseudomonas. Why? Because normally what happens, see, suppose this is your cornea and there is some foreign body fall because of which there was epithelial defect, and because of epithelial defect there was secondary inflammation and infiltration in the subepithelial tissue layers, right? So it developed ulcer. Now ulcer or the bacterial ulcer, the bacteria invade in the cornea like this, and it takes around 1 month, 2 months to perforate the cornea, to penetrate into deeper layers of the cornea and perforate the cornea. Normally the bacteria takes months, but attacks the cornea perpendicularly. It can perforate the whole cornea in just 72 hours. So if in question they give you hint number 1 that the patient is getting green color discharge, answer will be Pseudomonas. If they give you in question the history that the patient got perforation of the cornea in 3 days, answer will be Pseudomonas. Clear? Give me a thumbs up if it is clear. Pseudomonas clear? Okay. All right. Next important question right now. Question number 3. Most common cause of bacterial corneal ulcer in post-LASIK. patients. So the patients who have undergone refractive surgery, LASIK, these to get infections of the bacteria. Write down. Answer is atypical mycobacteria. Atypical mycobacteria. Write down the characteristic of this ulcer. It causes cracked windshield ulcer. Cracked windshield ulcer. The name of this ulcer is very, very important. It has been asked many number of times. Cracked windshield ulcer. Next important question, write down. Question number 4 is about characteristic point about nocardia is, write down, that it is associated with history of trauma will be there in your question. There will be history of trauma. And it mimics fungal corneal ulcer. So this is which bacteria mimics fungal corneal ulcer. Answer will be nocardia. Now, what is the characteristic of this ulcer which is caused by nocardia? It causes wreath pattern ulcer, or also called as pinhead ulcer. Very important question. Pinhead ulcer question has been asked many number of times. Pinhead ulcer is caused by okay. Now tell me, I have told you in the definition, what is the definition of ulcer? That there has to be a corneal epithelial defect. Discontinuity in the corneal epithelium has to be there. Only and only then there will be secondary inflammation and infiltration of the cornea, right? But there are certain exceptions. There are certain bacteria which can invade intact corneal epithelium without any epithelial defect. Okay, that is why these become very, very important for your exam point of view. So write down next topic or next question, write down rather. The name of the bacteria which invade intact corneal epithelium. And to remember these bacteria, the mnemonic which I am going to give you is girls' cornea. Girls' cornea, where G stands for Neisseria gonorrhoeae. Neisseria meningitidis. I stands for H. influenzae. I stands for H. influenzae. I stands for H. influenzae. L stands for R for nothing. L for listeria. L for listeria. S for shigella. S for shigella. Cornea. Con stands for, write down, in cornea. Con stands for Cornybacterium diphtheria. Cornybacterium diphtheria. So these are the bacteria which can invade the intact corneal epithelium, and they are very, very important. You have to remember this mnemonic. Now, talking about clinical features of bacterial corneal ulcer. Clinical features of bacterial corneal ulcer, they will give you a history in the question. Questions are never asked directly now these days, right? So they will give you a brief history. And what will be the clue point they will give you in the exam for bacterial corneal ulcer? In bacterial corneal ulcer, the symptoms will be more than signs. What do you mean by that? Suppose a patient comes to you with corneal ulcer and you examine the patient on slit lamp and you see very less mild symptoms, mild signs are there. Inflammation is less, but the patient is complaining of very severe pain, right? So that will give you an indication that this can be a bacterial corneal ulcer. So if symptoms are more than signs, it points towards bacterial corneal ulcer. Okay? Write down the signs of bacterial corneal ulcer. You will see hypopyon in bacterial corneal ulcer. What is hypopyon? Hypopyon is pus in anterior chamber. AC is anterior chamber in which aqueous humor is present, right? So when pus is present in anterior chamber, that condition is called as hypopyon. There is very severe inflammation inside the eye. And this hypopyon is sterile, plus it is mobile. It is mobile. Important question. Sterile and mobile. Is that pus is moving continuously in the anterior chamber like pendulum? No. Suppose you ask the patient with the hypopyon to lie down for 15 minutes, and when you ask the patient to sit again on the slit lamp, and you check the height of the hypopyon, you will notice that there is slight change in the position of the hypopyon. That shows that it is a mobile hypopyon. So sterile and mobile hypopyon is seen in bacterial corneal ulcer. Okay. This is how the pictures look like of a corneal ulcer. This is a big hypopyon. Can you see the pus is there, whitish pus? This is the location of pus in the anterior chamber. And this white part, this is infiltration of the cornea. This is the real ulcer, bacterial corneal ulcer. Right? Can you see congestion is there? In the conjunctival congestion is there. So eye will be red. Eye will be severely congested. You will see a big hypopyon. You will see infiltration or the corneal opacity will be there. Okay. And there will be sudden painful loss of vision. Sudden painful loss of vision will be there. Right on treatment. So in each and every patient of the ulcer who is coming to your OPD, you have to do scraping of the ulcer. So you scrape the ulcer with the 50 number blade usually we use, and we scrape the ulcer and we send the sample of that ulcer for culture and gram staining. Okay. And then based on that report of the culture and gram staining, after the result. Two important points you have to remember in bacterial corneal ulcer: steroids are contraindicated. CI means contraindicated. Steroids are contraindicated, and you don't need to pad and patch of the eye is contraindicated. Don't patch that eye which is having a bacterial corneal ulcer. Steroids are contraindicated. Why steroids are contraindicated? See, in Indian setup, what happens, the patients who are working in farms, they usually get this bacterial corneal ulcer or any foreign body ulcer. The patient goes to quack. They don't go directly to an ophthalmologist, right? So most of them goes to either pharmacist or most of them goes to quack doctors, right? So what the quack gives to the such patients, they give steroids. They give steroids, obviously, because there is severe inflammation in the eye. Steroid will give instant relief to the patient, right? But what is the harm in giving steroids? Steroids will give relief, but the healing will be delayed. Healing of the corneal ulcer will be delayed. Quack, who are not doctors, practicing illegally. So those steroids will give instant relief to the patient, but what is the harm in using steroids in bacterial corneal ulcer? The healing will delay. Healing of the ulcer will get delayed. Okay. So steroids are contraindicated. Now, what is given after the reports have come of the culture and gram staining? You will give fortified antibiotics, plus you have to give cycloplegics. As I have told you, cyclo means ciliary body. Cyclo means ciliary body, and plegics means paralysis. So the drugs which causes paralysis of the body are called as cycloplegics, like atropine, hometropine. So what will happen? These cycloplegic drugs will help the patient in reducing the pain. So pain is reduced in ophthalmology when we give cycloplegic drugs. Okay. And what is fortified antibiotics? So these are the combination of two drugs which cover gram positive as well as gram negative coverage of the bacteria. So we have to prepare these antibiotics in our clinics by ourselves. That is why they are called as fortified antibiotics, which cover both gram positive as well as gram negative, or anaerobic coverage is there. Okay. So these are fortified antibiotics, and this is a treatment which we give in bacterial corneal ulcers. This is all about bacterial corneal ulcer. Next, we will discuss fungal corneal ulcer. Now, as I told you, the catch point in bacterial corneal ulcer, what was the catch point in the history? That the symptoms are more than signs, means patient is having more pain. See, someone has asked me that treatment only give after results, then mean while what we will do to the patient, sir. Okay. So if you go by the books, book says that you have to start the treatment when your culture reports have come. But in practical life, in practical scenario, this is not the scene. Whenever patients come, you have to give them treatment. Okay. So we start the scraping we have done. We send the sample to the microbiology lab. Meanwhile, we can give fortified antibiotics which can cover gram positive as well as gram negative or anaerobic coverage. Okay. After 3 days, when the reports come, we can switch to another class of drug if the patient is having anaerobic infection or gram positive infection. So anyhow, you have to start the treatment day one. Okay. with cycloplegics. If you don't give cycloplegics and you start fortified antibiotics only, patient will have severe pain and he will go to another doctor. So in order to relieve the pain, you have to give cycloplegics also. Clear? Give me a thumbs up. Okay. So in fungal corneal ulcer, the catch point they will give you in history, in the question itself, that signs are more than symptoms. Signs are more than symptoms. What does it mean? That whenever the patient is coming to your OPD and he is made to sit on the sit lamp, patient is sitting comfortably. But when you examine the patient is having a big hypopion, big size hypopion, very severe inflammation, but patient is sitting comfortably. Relatively, there is less pain. This gives you a clue that it can be a fungal corneal ulcer. It can be a fungal corneal ulcer. Write down most common cause of fungal corneal ulcer. Question, write down. Most common cause. Answer is Aspergillus fumigatus. Aspergillus fumigatus. Most common cause of fungal corneal ulcer. Second important point, write down, clue point, which will be given in the history. Patient will give you in history of trauma with vegetative matter. There will be history of trauma with vegetative matter, means it is most commonly seen in farmers. Trauma can be with the animal tail, or they can give you in history that the trauma is with crop leaf. Okay, so this will indirectly give you a clue that this is a fungal corneal ulcer. Patient gives you history of trauma with vegetative matter, means animal tail, crop leaf, and most common setup is seen in farmers. Most commonly it is seen in farmers. So, or it can also be seen because of prolonged use of unwarranted steroids. Suppose a quack has given steroids to the patient for 7 days, patient got relief, and the patient is putting the steroids for 3 months. Automatically, the patient will develop a big corneal ulcer, which can be of fungal corneal ulcer, fungus origin. Clear? Now, talking about clinical features, signs are more than symptoms, as I have told you. The clinical features are very, very important in fungal corneal ulcer. And the mnemonic which you have to remember in fungal corneal ulcer, remember the mnemonic red fish. Red fish. What was the mnemonic for midriatrics? Can you tell me in the message chat box? Mnemonic for midriasis. Symptoms for bacterial corneal ulcer, patient will have same symptoms. There will be sudden painful loss of vision with watering and foreign body sensation. Pain will be there. High coughs, big oats. High coughs was for meiosis and big oats for midriasis. Okay, good. So, clinical features, remember the mnemonic red fish in fungal corneal ulcer. Where R stands for, we are talking about the characteristic feature of the ulcer. Where R stands for the ulcer will have rolled out edges. Ulcer will have rolled out edges and it will be elevated ulcer. It will be D for dry looking ulcer. If they give you in question that answer will be fungal corneal ulcer. So the ulcer will have feathery margins, very important. Immune ring of Wesley. Immune ring of Wesley. S stands for satellite lesions. H stands for hypopion, which was also present in bacterial corneal ulcer, but in fungal, hypopion is immobile, plus it is non-sterile. It is non-sterile also. What is satellite lesion? Suppose this is the picture of the cornea, this is our pupil, and somewhere here is the infiltration of the ulcer, right? But despite this side, there are certain small lesions in the other side also. These lesions are called as satellite lesions. Now coming to treat diagnosis, how you make the diagnosis? Again, for each ulcer, send scraping. So you have to send the scraping if you are doubting fungal corneal ulcer. Send the scraping for smear on KOH wet mount, and you have to do culture with seborrhoeic dextrose agar. SDA you have studied in micro. You culture the fungus with SDAs, seborrhoeic dextrose agar. Talking about the drug of choice. Drug of choice will be 5% netamycin in fungal. You have to remember the percentage also, 5% netamycin. Because it is fungal corneal ulcer, so you have to give antifungal, which is 5% netamycin. Plus, which other drug you have to give? You will tell me. In fungal corneal ulcer, which other drug you have to give? Despite antifungal. Message me in the chat box which other drug you have to give despite netamycin. SDA is seborrhoeic dextrose agar. Seborrhoeic dextrose agar. Acyclovir is antiviral, so there is no point of giving antiviral in antifungal ulcer. Azoles, no. As I have told you, the patient is complaining of severe pain, and if you don't give cycloplegics, pain will not be relieved, right? And patient will be unhappy. So, in order to relieve the pain, you have to give cycloplegics, not NSAIDs. You have to give the drugs which causes paralysis of ciliary body, so that pain decreases, right? And these are cycloplegic drugs. Example, as I've told you, atropine, hometropine. Symptoms will be the same. See, ulcers will have same symptoms. There will be sudden painful loss of vision. There will be watering. There will be redness. It will be same. Pain severity they will differ in bacterial, in viral, in fungal. So the severity of the pain will differ. Rest, all the symptoms will be same. There will be sudden painful loss of vision with redness, watering, foreign body sensation. So those symptoms are same. Clear? So you have to give 5% netamycin along with cycloplegics. Name of cycloplegic is atropine, hometropine. Clear? So this is all about your fungal corneal ulcer. Next type of ulcer we will discuss viral corneal ulcer. Viral corneal ulcer. Tell me the name of the virus which you have heard in corneal ulcer. Any idea? Herpes. Any other options? Herpes simplex or herpes zoster? So write down. In viral corneal ulcer, we will discuss the most important one for your exam point of view, which is herpes simplex virus. Simplex virus keratitis. HSV keratitis, herpes simplex virus keratitis. So this herpes simplex keratitis has many or 5 subtypes. It can manifest in clear? It can manifest in either of the form. It has 5 subtypes and each of the subtype is very important. Each of them. First one is HSV keratitis causes superficial punctate keratitis. Superficial punctate keratitis, what picture you see, suppose this is the cornea, you will see multiple dot-like epithelial means the lesions are limited to the superficial layer of the cornea. It is not a very deep infection. So you will see multiple dot-like epithelial lesions in superficial punctate keratitis. Second is very, very important. It can cause dendritic ulcer. Dendritic ulcer. So how the picture looks like, this is the cornea, suppose. So if an ulcer patient comes to your OPD and you examine the patient on slit lamp, can you tell me how you will examine the patient of the ulcer? How you will see these multiple dots? Which dye you will use first to stain the cornea? The name of the dye which you use to stain the cornea in OPDs. Orange color dye. Fluorescein dye. Fluorescein dye, right. And another name of this other dye was red. Other dye, rose Bengal dye. The name of other dye was rose Bengal dye. The reason why it is not commonly used was because it causes stinging sensations to the patient, right? So you have to stain the cornea and then you see the ulcer. Clear? So these dendrites, how the dendrite looks like this. You will see certain dendrites like this, branching pattern you will see, and you will see terminal knobs and buds are seen. These are called as terminal buds or terminal knobs. These are the characteristic finding of a true dendrite. These are the true dendrites which have terminal knobs and buds. So how they look like, let's see the picture also, because they can come directly as an image-based question also. If you can you see the linear branching pattern having terminal knobs and buds like this? These are called as dendrites. Typical picture of dendritic ulcer seen in herpes simplex keratitis. Okay. This question can be asked as image-based question also. Now talking about the third subtype of HSV keratitis. Third subtype. The name of the third ulcer is geographic ulcer. Geographic ulcer. How the picture looks like, again draw the diagram. This is a amoeboid shape ulcer, like this. Like this. So this type of configuration, if it is present, amoeboid shape, this is called as geographic ulcer. So in all these three types of ulcer, in all these three types, three subtypes of HSV keratitis, write down. The drug of choice will be, now you will tell me the drug of choice, keratitis or the viral corneal ulcer. What will be the drug of choice? Please tell me. In viral, which drug you will give? Antiviral. And antiviral is acyclovir. Along with acyclovir, what else you will give? What else with the acyclovir? Obviously, there will be pain. Cycloplegic will be given, right? So in these three subtypes of HSV keratitis, the drug of choice is 3% acyclovir. This percentage also you have to remember. Can you tell me what was the percentage of netamycin? Netamycin was 5%, whereas this acyclovir is 3%. So 3% acyclovir ointment is given with cycloplegics. What is contraindicated? Can you tell me which drug is contraindicated? Contraindicated in these three subtypes of HSV keratitis, steroids, right? Steroids are contraindicated. Good. Steroids are contraindicated. Good. Now talking about the fourth subtype of HSV keratitis. It is called as disciform keratitis. Disciform keratitis. Now this disciform contains, it has D, right? It has D in it. So another name of disciform keratitis is also called as endothelitis. How you will remember this? Endothelitis also contains D. D for disciform and endothelitis. Now, what do you mean by endothelitis? Means that the keratitis infection is such severe one that it is involving the deeper layer of the cornea, right? Deeper layer means endothelium. So infection is such severe that it is invading the endothelium of the cornea. Clear? So in such disciform keratitis or endothelitis, write down, becomes important because, and you have to give steroids in disciform keratitis. That is why this question becomes important for your exam. Because we are giving steroids in this viral ulcer, this keyform keratitis, you have to give steroids. Clear? Coming to the last fifth subtype of HSV keratitis, it is called as neurotrophic ulcer. Neurotrophic ulcer, also called as metaherpetic keratitis. So as the name suggests, neuro means something has to do with cranial nerve. Something has to do with your cranial nerve. That is why the name is neuro, right? So what is the relation? This neurotrophic ulcer, write down. This is seen due to fifth cranial nerve palsy. It is seen due to fifth cranial nerve palsy. Can you tell me the mnemonic for, what was the mnemonic for corneal nerve supply? Mnemonic for corneal nerve supply. What was the mnemonic? Please hurry up. LGB, no. LGB was for neurons, first order neurons, second order neurons. TON, yeah, DON. So TON was the mnemonic where T was trigeminal nerve, right? So if there is any palsy of trigeminal nerve, what will happen? There will be no nerve supply to the cornea, right? And there will be a situation which is called as corneal anesthesia. It will lead to corneal anesthesia. And when there is corneal anesthesia, there will be failure of re-epithelialization. Epithelial will not heal. Epithelium has regenerative potential. But in such ulcers where there is fifth cranial nerve palsy, which leads to corneal anesthesia, there is no nerve supply, it leads to failure of re-epithelialization. This is an important question. So neurotrophic ulcer, you have to remember, it is seen because of fifth cranial nerve palsy. Fifth cranial nerve palsy. So all these 5 subtypes are very, very important for your exam point of view. Dendritic ulcer is very, very important, right? And disciform becomes important because you are giving steroids in these infections. And neurotrophic becomes important because it is seen because of trigeminal nerve palsy. There is failure of re-epithelialization. Question has been asked on this point. Failure of re-epithelialization seen in neurotrophic ulcers. Clear? Now coming to next type of infection or next type of ulcer, write down. Acanthamoeba. Acanthamoeba keratitis. Acanthamoeba keratitis. Write down. Very, very important. Most common cause of acanthamoeba keratitis. Write down. Most common cause is contact lens users. Again, culprit is contact lens. Now can you tell me, most of you must be using contact lenses. What is the problem in contact lenses? Where is the source? What is the source of infection in contact lens? Any one of you? What is the source of infection in contact lenses? Is outflow decreased, liquid used to keep lens? Yes, right. So the problem lies in contact lens solution. Problem lies in contact lens solution. You have to regularly change these solutions and they should not be contaminated. You should not wash your contact lenses with normal tap water. Okay. So most common cause of acanthamoeba keratitis is contact lens users. And write down the problem in contact lenses. It lies in the contaminated contaminated saline solutions. Problem lies in contaminated saline solutions. So most common cause is contact lens users. It can also be acquired. It can also be acquired from swimming pools. Important question. So if they have given in history that two children were swimming in, they were doing swimming, right? Or they were swimming in pond. And they got sudden painful loss of vision and there was watering. So it gives, indirectly, it gives you hint that it is acanthamoeba keratitis. Okay. Coming to clinical features. Again, the symptoms are more than signs. And the patient present to you with severe, very severe pain. Very, very severe pain, which is out of proportion. Which is out of proportion to ocular involvement. Now, if you ask me, which is the most painful, bacterial keratitis, fungal keratitis, viral, or acanthamoeba? So out of all these, pain-wise, if you ask me, acanthamoeba is the most painful one. Why? Because this acanthamoeba is directly affecting your corneal nerves. It is affecting your corneal nerves, right? It is causing neuropathy. So that is why the pain is out of proportion to your ocular involvement. Clear? And that involvement of the nerve is called as, write down, signs. It causes radial keratoneuritis. Radial keratoneuritis. It gives you perineural infiltrates. Perineural infiltrates are seen, which are the pathognomic sign. Pathognomic sign of acanthamoeba keratitis. Now, suppose this is our cornea, this is our pupil. These are, suppose, small corneal nerves which are supplying to the limbus. So, problem with this is acanthamoeba, that it invades your corneal nerves and gives you infiltrates in the corneal nerves. So, these infiltrates are called as perineural infiltrates, which are pathognomic sign of acanthamoeba keratitis. That is why, because it is involving the nerves, that is why these are very, very painful ulcers. Understood? Give me a thumbs up if it is clear. Okay. Now, next important sign, write down. Apart from radial keratoneuritis, next important sign is you will see pseudodendrites. Pseudodendrites. What are pseudodendrites? We have talked about dendrites, right? Dendrites were with linear branching ulcers with terminal knobs and buds, right? Like these. These were the terminal knobs. Now, if these branch do not have any terminal knobs or buds, then they are called as pseudodendrites. They are called as pseudodendrites if they don't have terminal knobs. So pseudodendrites are seen in acanthamoeba and dendrites are seen in HSV keratitis, disciform keratitis. Next important sign is you will see ring abscess and hypopyon. ring-shaped abscess is seen. Important question. Ring-shaped abscess is seen in which type of ulcer? Acanthamoeba. So someone of you has asked once again radial keratoneuritis. As I have drawn this diagram, these are the nerves which are supplying to the cornea at the limbus. This acanthamoeba directly invades the corneal nerves. That is why it is called as radial keratoneuritis, and that is why it is causing severe pain to the patient. So important signs are radial keratoneuritis, pseudodendrites. Why pseudo? Because pseudo means false. Why they are false dendrites? Because they don't have terminal knobs. Like true dendrites. True dendrites have knobs. Pseudodendrites don't have any terminal knobs and buds. Third important sign is ring abscess with hypopyon. How the ring abscess looks like? Let us see. So this is the picture, typical picture which is seen in acanthamoeba. Can you see, appreciate this white circle or white abscess is there? This white disc-like abscess is a typical finding seen in acanthamoeba keratitis, and this is called as ring abscess. This is called as ring abscess. Now coming back to the investigation. These are the signs. Coming back to investigations which you carry in acanthamoeba keratitis. So again, you have to do culture. Question is asked on culture media. Culture media which is used in acanthamoeba keratitis. Very, very important question. It is cultured on non non-nutrient agar enriched with E. coli. Very important question. So they will ask you the culture media for acanthamoeba. Answer will be non-nutrient agar enriched with E. coli. If they ask you what is the drug of choice for acanthamoeba keratitis coming to treatment, then answer will be PHMB 0.02%. Percentage is not important, but the name is important. The full form is polyhexamethylene. Polyhexamethylene biguanides. It is a drug of choice in acanthamoeba keratitis. Next type of keratitis, write down short. This is interstitial keratitis. Interstitial keratitis. So what do you mean by interstitial? Interstitial means some interstitial layer of the cornea is getting infected in this type of keratitis. Or the middle layer of the cornea, that is your stroma, right? So as the name suggests, in interstitial keratitis, there is only stroma. Which is asked is write down, which is the most common cause of interstitial keratitis? Answer will be to remember in interstitial keratitis. So which layer is only involved? Stroma. And most common cause of interstitial keratitis is congenital syphilis. Where we have studied congenital rubella syndrome before. Can you tell me in the chat box? Congenital rubella syndrome. It was associated with congenital rubella syndrome was associated with, please hurry up, microcornea or macrocornea? microcornea. Right. So this is all about interstitial keratitis. Last, write down neuroparalytic ulcer. So the name neuroparalytic ulcer is phonetically similar to which type of ulcer we have studied before in HSV keratitis? It sounds phonetically similar to which ulcer in HSV keratitis? The another name was metaherpetic, which was because of which cranial nerve palsy? Fifth, neurotrophic, right? Neurotrophic was because of fifth cranial nerve palsy, right? And this is neuroparalytic. So just remember only one thing, that this neuroparalytic occurs due to facial nerve palsy. Just one thing you have to remember. It occurs because of facial nerve palsy. And neurotrophic was because of fifth cranial nerve palsy. Clear? So this is all about cornea. So I'll end here only today, and we will discuss rest of the chapters tomorrow, same time. Any queries you have? Thank you. Thank you so much for listening. Please revise. PDF I'll send you on Sunday, the final day. PDF and all the images I'll forward you.